Hi, everyone, and welcome to today's presentation. My name is Chloe Setsos, and I'm the project coordinator here at Capital Link, and I'd like to thank you all for joining us today. Today's webinar, entitled Focus on Behavioral Health, Utilizing Cost Data to Drive Programmatic Change, is the fourth and final webinar series offered through the Delta Center for a Thriving Safety Net. The full series, entitled Understanding Your Costs in the Evolving Payment Environment, will be found on our website, and it is developed by Capital Link with input from JSI, and we'd like to thank the Robert Wood Johnson Foundation and the Delta Center for supporting this effort. You can access these recordings and PowerPoints from the prior webinars in the series on the website of the Capital Link Delta Center. Today's webinar will also be recorded and posted on the website. Today's presentation will last 50 minutes with 10 minutes for questions at the end, but feel free to ask questions throughout the presentation in the chat box located in your GoToWebinar. Even if we went over a few minutes, we still will take the time to answer your questions. Today's speakers are Dave Kleiber, who's our project consultant at Capital Link, Bob Urquhart, consultant and retired FQHC CFO. We also today have Anya Eliason, interim CEO, CFO, and Nicole Lawson, deputy director at COO at OCHN. With that said, I'll turn it over to Dave to get started.
Thanks, Chloe, appreciate that. And we are extend my special welcome to Anya and Nicole from the Oakland Community Health Network out of Michigan. This one, this is our fourth session. As you can tell from the title, is a little bit more about negotiating, using the cost data that we've talked about to negotiate with your payers. And as it turns out, we're fortunate enough to have a couple of payers with us on this call. So we're going to try to structure this a little bit as a conversation as we go. We have slides to cover, but I would love to see if you, the audience out there, if you have questions about that dynamic between the providers and the payers, and I know there's a mix of you out there in the audience. Use your chat box. Send us questions as we go. We'll answer them as we see them, and hopefully, this of course, as Bob knows, this would be unusual for us, but we may actually have time at the end for questions as well. But we will field them as we go. Let's turn the slide over there as I also echo your thanks to the Delta Center and JSI and Robert Wood Johnson Foundation for support in the development of this webinar. We've been appreciative of that, and here are the topics that we've covered so far. So the first one was a basic 30,000-foot kind of walking through the calculations to generate costs on an organizational basis. And then largely Bob drove the discussion in session 2 with more detail about the costs and how you develop them on a detailed basis, down to your chart of accounts and how to structure that so that you can actually have the tools needed to drill down to get the costs you want. And we'll talk a little bit more. We'll have an example here today about that. And it's necessary in order to be able to have that level of detail in order to do this at the level you'd want to. And the last session was more of a drill down to talking about outcomes and how do we measure outcomes? How are they impacted by things like the social determinants of health, and how do we measure them through perhaps patient surveys and HEDIS measures and the like? So we get now to this fourth session. Next slide, please, Chloe. We get now to this fourth session, which is really, again, we've put this slide in every one of the 4 presentations for a reason. And it's because it's still basically the case that this is the challenge we face. What does an evolving payment environment mean to each of you and to each of us? We sit in different seats. We have perhaps different definitions of what that means. But for the providers out there, it's important to realize that basically we're dancing to the beat that's set by the payer. And if your payer begins to talk about a value-based system, or to start judging you, or judging is a harsh word, but evaluating you on more than just producing out the statistics, just having visits, you want to be able to be part of that conversation. And so, we talk through these three where we have to define and measure the outcomes, which we went through in the last session and still is very much the case. We have to be able to calculate those costs based on the outcomes we're after. And then the third part is going to be what we talk about today a little bit more, which is if we're going to stay in business, we need to get reimbursed for those costs that we've generated. So think about it really quickly at the 30,000 foot level. If you had someone making, $100,000 and you counted in your cost analysis all the hours that you paid them for, and said, okay, well that doc, whatever, the therapist is making 100,000 and roughly 2,000 hours a year since they're a full-time equivalent employee. Well, that's $50 an hour, except that they're not available all the time, and they have vacation, and they have professional education time. So we're going to drill down in this session a little bit more later on to talk about how you more accurately reflect the real cost, so that when you go in to talk to your payers, you're armed with those better numbers. Because if you drop those hours, that actual cost per visit of that person, we use this example, goes up. And that needs to be reflected in the analysis you bring to your payer. Okay, next slide, Chloe. So regardless of how we feel about it, we're in an environment now where we're under pressure, we being the providers largely, but the payers as well, obviously, because they're answering to the large federal payers largely, under Medicaid, Medicare, to reduce costs, or at least to control our costs better. And that seems unfair on many levels to the behavioral health world, because you've always been under reimbursed. So to kind of saddle that, this portion of the healthcare environment with and mandate to reduce costs seems kind of not fair, since you hadn't really enjoyed in all the good times of being reimbursed for your higher costs. But that is what it is. So we need to recognize that we have to deal with that pressure regardless. So, what does that mean? How do we react to that? Well, obviously, first we maintain focus on and fidelity to the quadruple aim. And as we all know, that's, lofty goals, population health and improved individual experience of healthcare, and, controlling costs within that, as well as improving the provider experience. But if we're going to now focus largely on that cost element of it, what do we do with that? How do we go and reduce those costs while we're still meeting those other triple aims? And what we want to say with this slide is that stand back a little bit and realize that you don't need to reduce costs across the board necessarily. What you need to do is to know what your costs are for each of the programs that primarily what you're offering to your clients. And so you can decide maybe not all costs need to be reduced. Perhaps there's areas where you could actually spend a little bit more, get the results that your payer is looking for, and actually save the system money. So that goes back to being able to demonstrate outcomes, identify outcomes, and report on outcomes again. So that flips back to our last session a little bit, and we'll be talking more about that. I will ask Nicole and Anya to respond a little bit to that idea of how do you view the mantra of reduce costs. Do you have a message that you send to your providers, kind of maybe not in an email, but that's just the tone you set with them as far as what your expectations are in trying to contain costs? Does this make sense to you that you could be spending more in order to save more down the road?
So this is Anya. I'll just jump in and Nicole can add when I'm done. For us, the idea is outcomes. It's not always about the upfront investment. It's the long-term outcome for that individual's life. And what we have seen is that, sometimes when you're putting in extra money in the front end, you're able to reduce things on the back end, such as hospitalizations and things like that. So it's really about being as efficient as possible and focusing on really what we want the outcome to be, not just looking at the cost and how do we cut the cost. Nicole, would you have anything to add to that?
I mean, the only thing else that I would add to what Anya had said would just be that maybe we're a little bit more unusual than some other payers in that we have no profit or no gain in just arbitrarily cutting costs to kind of save on the back end. So, you know, we run at about a 95% or higher MLR. And so we're very much just mission driven in that way. So that might be a little bit maybe different than other payers out in the world.
So, Nicole, I'm going to interrupt here a little bit. Could you describe that 95%? Say that again and maybe describe a little bit what you mean by that and how it impacts how you work.
Sure, sorry. So that's our medical loss ratio, and Anya can certainly jump in and correct me as the CFO if I misstep. But essentially what that means is that for every dollar that we are funded, 95 cents goes directly towards service delivery. So it means we keep our own admin and overhead costs as low as possibly can in order to invest as much as possible into services for people. So like Anya said, if you're talking about the 95 cents on every dollar, we would rather pay more to have someone living as independently as possible in their community and having a successful, fulfilling life versus paying for institutional care or hospitalization because they don't have the needed clinical or community supports that they have. Anya, would you add anything about the MLR in there?
Nope, other than to say we do have expectations related to administration at a service level as well, because while we hold ourselves to a very high standard, we also expect our providers to be held to a standard as well, because again, we are a publicly funded system and our focus is on providing services.
And that's great. We're going to dive into that a little bit more down the track here. But that's exactly, I think, the message that we want to have and the conversation we want to have with our audience here today about just the roles you individually play. So you're, the provider sitting out there thinking, okay, I'm dancing to the tune of my payer, but the payer in turn is responding to, and as you mentioned, the taxpayer to something to a large extent, and the Medicaid system within your given state. So it's not like you're sitting there with controls on all the levers. You also have to be responsive to who's providing you with the funding. Next slide, please, Chloe. So here's where, Bob and I like to, we talk in sports metaphors often, but in this case, the overall message is that, in fact, you as a provider, and I do tend to take that view a little bit more, and that's why it's great to have OCHN here as representing the payer side. But it's important, in my experience, sitting on boards of community mental health agencies, my sense was never that we were really playing offense. We didn't take to the payer very often. We might complain about our rates. I think we've all done that a little bit, and then what we're paid, it's just not enough, it's not enough. But did we actually go in and talk to the payers on hey, let's think about this, let's think about that. Let's be active in the formation of the programs and not just reactive to what rate comes out at the bottom end that we end up receiving for various services. So what happens when in the development, as the payers become more reactive to a value-based payment system, so as they evolve, the providers are going to have to evolve along with. But that's a process that you don't want to sit on the sidelines and watch happen. I think it's important that there are dangers if the whole medical establishment in your state it gets too overly focused on the medical response and the medical outcomes. You need to make sure that early on that behavioral health plays a major role in how they view the costs. Now, when I was at that particular, the last one that I was board chair of, I sat with the CFO many times, and we never walked through the list, but I was aware that he had the list of what they called hotspotters at the time, people who were costing the system the most, and the classic 20/80 system played along. But it was interesting that that's the big money, right? The big money to the state is being spent on relatively small number of people, almost, and this is medical and dental, oversees the whole thing, most of which interact with our systems, the behavioral health systems. So whereas your client base may be seriously mentally ill and the seriously persistent mentally ill and emotionally disturbed people, you have to realize that in a sense that provides you with some leverage in the negotiations, because these are the folks who, by and large, not universally, but by and large, are costing the system a lot of money. So it's important to get in early to be able to talk to your payer, because if they don't have the incentives based in their system to encourage good behavioral health care, it may not be in there. And it may be too late once the program's developed and rolled out that you wave your hand and say, well, wait a minute, we have this great idea, or we have this great treatment methodology to interact with these people and possibly reduce costs long term. But it's not included. You're not valuing it because you're not paying us for it. You need to get in and again play offense, get in front of those folks. So again, I'm gonna ask Nicole and Anya to respond a little bit. Has that ever happened in your experience in Michigan? Have you had providers kind of talk to you and say, look, we've been trying this system, or we came up with a treatment methodology that we find is working really, really well, and we want to run it past you as a proposal for a reward to kind of get a value-based payment out of it if in fact our results are as good as we think they are? Is that, or have you been driving the bus basically, or has it been a joint effort?
Sorry, I couldn't get to my mute button fast enough.
Sorry about that.
So I would say, at least in my recollection, it's typically us, but what we do typically get back from providers is, as we roll out new things, if they don't feel like they can make it work, what we always say is, okay, bring us your info. Let's sit down. Let's talk through where your stuff is different than the numbers we're using, where your costs are materially different. I don't know that I can particularly, Nicole would be a better person to answer from a clinical perspective if anybody's come to us with any like new evidence-based practices or anything like that that we've added. Nicole, do you have any thoughts on that one, or is it really just more kind of what I'm thinking?
Yeah, it's along those lines, and I don't know that anybody's come to us with a new practice that they've rolled out to say, hey, we already have these outcomes. They have come to us and said, have you thought about measuring this outcome? Or, we think we know where you're headed, but we think, maybe if you measured this data point and held us to this standard versus this one, it would get you closer to what we think your actual goal is. So, I think we initiate, and we have initiated across every different model we've done to date. But the process does become a lot more collaborative kind of after we get through that initial rollout, and collaboration across the board in terms of how things are costed, how things are funded, and what outcomes that we're looking for.
Thank you. That's good. I mean, so it does sound like there is a role. You're open to it, to hear from your providers in this early on in these stages. Chloe, can we talk to move the next slide, please? So, the payment reform, just shifting gears a little bit from that, the payment reform evolution, if you will, has happened to where I noticed that you guys at Oakland are paying on or at least part of your system pays on a per member per month basis, which is fairly unusual in the behavioral health world, most of which being at the bottom there at fee for service. And then care coordination has already been noted as well. So as an add-on, perhaps as a carve out, some funding for that. And then we're in some select areas, we're hitting the pay for performance, which I think, the certified community behavioral health system might be justified to be called a P4P system. There's some savings in some areas. You can participate in the quality rewards, if you will. And then I'm sure there's too many downside risks, but you can see that third level is kind of where things are going. Perhaps more in medical than in behavioral health, but we're still I think this is almost an inexorable evolution upward in this trend. So you can identify where you are, both as a payer or as a provider in this and kind of get a little bit of a vision of the future and how that might work. Next slide, Chloe. Thanks. So I'm going to turn this over to Bob for a little bit of quick review, because we've been talking about costs again, and we've been talking about outcomes. And so let's have a quick run through as to what that means in this world. Bob?
Yeah, good afternoon, everybody. For those of you who've been through these sessions with us all along, you've heard this message, but it's worth repeating. And one of my favorite sayings is, your costs are your costs, and you have to know them better than anybody else. I think that we've talked about in prior sessions, the setting up chart of accounts to capture things at the lowest level possible, to be able to determine where is your money going and where is your return on that investment. Most people don't like to hear the term losing money, surplus deficit in healthcare, because it's almost opposite of what we're trying to do. We're trying to make people better. However, to be able to make people better, we have to be here for the long run to do that. So good cost accounting, identifying where you're putting your resources is important. It also helps you internally in terms of making decisions. I've worked in organizations where the bottom line isn't what people want it to be, and they decided we're doing a across the board 10% reduction. Well, that could be a very bad thing to do for one part of your operation that's doing very, very well, and you could actually hurt yourself by doing that. So being able to look at what actually is happening and where your units are performing, and strategically deciding what you're going to do. It might be we're going to take money from one and invest in the other, or we're going to slow down on one. But you need to be able to have the specific detail to get there. And understanding your cost helps you. It helps you with this. And going back to this a couple of slides ago with the playing offense, it also helps you when you're still with the payer and you're doing. We have annual rate reviews, and you sit back and say, well, here's what our costs are. Our costs have gone up, and here's where they've gone up. And here is how we're trying to control those costs. So can you help us out with that? So it helps you in that end as well. Next slide, please. In session one, we talked about the components of, we concentrated on cost per visit, cost per client, trying to break it into pieces so that you can understand where your costs are. Provider cost being the cost of the provider in the room with the patient providing that care, their salary, their benefits, and what is the costing for that part of your service. Direct support cost, any nursing, any MAs, any registration folks that are helping deliver the visit or the care that day to that client, gets captured in there, along with all of the other costs related to that. Medical supplies, office supplies, both kind of things that are on your income statement. Enabling cost is kind of a broad category, and every organization may be a little bit different and how you define this. But I'm defining this in the behavioral health world as, we're helping somebody by providing transportation to get to an appointment, providing transportation to get them to a specialist we want them to go to, providing meals to help the patient out, providing some assistance with getting medication. So that will be captured in here as a separate piece of your cost per client. Then the overhead costs, obviously the patient accounts costs, the finance costs, human resource costs, IT costs, all of those other costs are running the business that aren't necessarily part of the touching the patient part of it. This particular category, these breakdown of the categories comes right from a NAC study that Dave and I worked on years ago. And there's a bulletin you can get, and I think it's referenced a little later on, but this is what we're recommending, and you can break these things into this. When you see where your cost per client are, it's a more strategic way to go look at where you want to make a change, if you want to make a change. Next slide, Philly. And the time is money. Of course, the most expensive resource in healthcare is people. That's where all the expenses are. 80% of most healthcare organizations, 80% of their expenses are people, with the salaries and benefits. So being able to look at the time devoted to each clients, that how much time we're spending and where are we spending it. What is the capacity of each resource? I mean, how many hours are they available? How many clients can actually see what's that resource capable of doing. And the same for support cost. You know, every person that's dealing with the client, what is it costing us for that interaction? So the time is money thing is it's being able to understand if it's taking us 1 hour to deliver a client encounter, what is the cost of that using the time for each one of these people to provide that service? Next slide, Chloe. All right, so we talked about this in the prior session, but essentially what we're recommending is that, you know, to get a handle on this, to go back and figure out where you want to go, to start with historical average on a per client basis. What, you know, go back and look at the last couple of years and what has your average cost per client been? That's the starting point. And then if you're going to look at developing pathways and specific care plans for people, stratify the clients. How many clients are there and what you want to try to do. Identify the pathways for the groups of clients with similar needs. So you're going to look at your past history on cost per client. You're going to stratify that based on this cohort of people that you want to try to provide this particular care to and develop that pathway. And then when you know those things, what are the unique costs to do this that you would have to build into your historical average? So you might be going along doing something every same way for 2 or 3 years. Now you develop this clinical pathway, you develop a new treatment plan or a more intensive care program for a certain cohort of your clients. What are the unique costs that you have to add to your base to be able to help you understand what is really costing you for that particular care pathway? And that's, so we've talked about that in the previous sessions. You can go back and look at that in more detail. Next slide, Code.
Yeah, thanks, Bob. Yeah, thank you. That was good. So we did in session number 3 talk a little bit more in depth about the concept of care pathways. And we're going to use what is called assertive community treatment as an example of that. And this is a program that Nicole and Anya are going to describe in a little more detail here coming up. There are others that could fall into this bucket, obviously. This is the idea being that there are clients of yours who obviously are all individuals and they all have their own individual needs, but their care could fall into kind of a pattern in a sense that there's a group of therapies or outreach or interactions you can have with them uniformly, if you will, which can then be costed so they more carefully, and you can put those together, which we'll do here on the slides here in a minute, and walk you through. But first I'm going to have our 2 guests from Oakland Community Health Network describe that assertive community treatment program in a little more detail so you understand where they're going with that, and then we'll cost it out. So Anya and Nicole, do you want to take over? Next slide, please, Chloe.
Sure.
Okay. Go ahead, Nicole. I just want to make sure I wasn't interrupting you, and I did.
Yeah, I figured I could maybe give an overview for those who aren't familiar with assertive community treatment or ACT. It is an evidence-based practice. It's our most intensive community-based service that we have in our continuum of care for adults with mental illness. And it's a multidisciplinary team. So it consists of doctors, nurses, therapists, case managers, as well as peers. So people essentially have those services kind of wrapped around them, and they receive all of those services in the amount, scope, and duration that is medically necessary for their particular needs. So here in Michigan, the basic makeup of an ACT team allows for a caseload for the team of up to 20. And then that's maximum. So once you hit 20, then you have to start adding on case managers, therapists, and peers, as well as doc and nurse time in order to meet the needs of more people. So for the purposes of the example that Anya and I are going to walk you through, these are for traditional ACT teams who can serve up to 20 people at any given time. So with that, I'm going to turn it over to Anya to walk through the basics of the funding.
Okay, thank you. So for the ACT model, what we did was, because it is such a prescribed team approach, the specific staff that are utilized, as Nicole mentioned, are very outlined in the provider manual that says how many staff you have and what those staff makeups are. So what we decided to do was to do a bundled rate, basically a per member per month rate for that team composition based on the number of individuals they can serve. And then any service they were to get outside of that group of individuals, if they were ancillary, things like different therapies and things like that, those are paid outside of that. So you can go ahead and go to the next slide, please. So I thought this was supposed to be the actual ACT rate development. Can you go to the next one? You might have to jump back after that. These are not in the order I expected.
Oh, sorry about that.
I was looking for
fault.
the costing one with
I think it's slide 16.
Yeah. So you can see here is taking the staff that are on an ACT team and coming up with basically the amount of time they're able to devote to providing direct services. So what that does is subtract things like vacation time and any other adjustments for indirect time. So what we would consider indirect time is time for paperwork and things like that. So those things have to be factored into the amount of time an individual staff has to provide direct face-to-face services. So I think if you jump to the next one, yep, so that one. So what that does is then you come up with the annual cost per year for that staff, adding in fringe and overhead and those types of things to come up with your total cost per team. And then what you do is divide that by the number of individuals that are able to be seen, and making an assumption that not all individuals are going to be seen every month, or that caseload won't necessarily be seen every month or be full every month, just due to turnover and those types of things. So what we did was back off just slightly from the expectation of a full caseload at all times, to come up with eventually basically per member per month reimbursement that covers all of the salaries of all of these individuals. I believe there's one more slide that I would like, hopefully it's next, yes. So this one, sorry, go ahead.
So I was thinking, I think if they're one of the three slides you sent, they're backwards, Chloe. I don't know but if this is the one you want to cover, that's fine.
Yeah, the one I'm looking for is not this one, but I can work through it if it's the next one too. That's fine. So again, this just speaks to the amount of time an individual has in a given year to provide direct face-to-face services, and gives you an idea of what cost it is for each of those particular services that might be being delivered. I think the next one is actually the one I was hoping to get to. Nope. So go ahead and go back to that one. All of that being said, the PM equivalent, you can see based on this calculation, is roughly $362, which I think is actually not too far from our ACT per member per month reimbursement. And you can see that adds in 45% overhead. And for us, overhead would include not only administration, but also additional staff to support the program, like support staff, or let's say receptionists, or those types of things. All of those things get factored into that to make sure you're covering costs of the entire team and the associated staff that go with that.
Yeah, that's good. And I'd point out here, if you're if you're following closely along, there's a couple of things here you might be wondering about, and we'll point them out in advance. One is obviously that 45% overhead ratio. So that's a figure you guys put into the slide that I kind of modified this from originally in your presentation. But it seems like a high number. There's probably a fair number of people out there in the audience thinking, oh, that's a big number. And you'll notice it's we just overlaid it as a single large number. So we asked effectively for the providers to give us all this detail, right? We've got those last 3 slides. By the way, those last 3 slides are basically one long Excel spreadsheet that are all tied together formulaically, but it's hard to get all that, the 3 of them be on one slide. But it does tie together. And so you're asking, you're drilling down on the provider side, but then we just lop in 45% on top. So if you're watching carefully, you're probably wondering, wait a minute, that doesn't seem quite fair, and you'd be correct. I think
I have something there, Dave.
Hello?
Yeah, Dave. Can I just, I think what I would add to that, when you look at the 45%, based on what Ryan just said, if you go back to our components of cost per visit, if there's a section they call direct support cost, and I think what's happening is that that's being added into this overhead, which is inflating the overhead. But if it was broken out into the non-clinical support staff, and that example we showed you a few slides ago, it would look different. But as long as the key message is knowing the cost and capping it all.
Yeah, I think you're right. I mean, this is the provider largely, but there's also going to be what we've been calling enabling. You could have a different definition out there in the audience for the folks, the support folks that are helping out, and who also may be part of that, and that number is why it's so high. But the point I'm trying to make is that there's that amount of money should probably be broken out in the same level of detail as we're doing here, in order to be both fair to the providers, but also to really get a good idea of your costs. Since it is such a substantial portion of the total cost, you need to drill down with the same level of, look through the same lens and treat it similarly. The other thing I'd point out here, especially on this slide, is that the big part of this is the numbers you put into the blue columns. So those are, there's nothing, they take this as an example. It's not gospel. This is not necessarily how you should be running your shop or how you'd run the assertive community treatment program where you are. But it just shows how many, you need to put a minute number into that column for the average time per interaction. It could vary for you. Then how many times do you envision in a year that they would actually interact? So those numbers are very variable. Don't take them as some kind of evidence-based practice or something. But be sure that they're an important part of this whole formulaic composition here to come up with that number. And so in a world where, again, we go back to talking about the costs and the size of the costs. So in a world where many on the medical side would be happy with a $25 per member per month for your basic medical primary care needs, here you're talking about over $350 per member per month. That's a lot of money. And there are others that, different types of these programs that you might be able to justify even higher costs because you've laid out this detail. Okay, Claude, do you want to move on to the next slide? So, this
Dave,
is where, go ahead.
Sorry, Dave, this is Nicole. I'm just wondering if we can go back to those outcome slides for a minute.
Oh, sure. So do you want the slides that you provided? Yeah, back, keep going, okay.
Yeah, there we go. So just to kind of round out how we've done the ACT model. So we have the PMPM that we pay, and like Anya had mentioned earlier, we are a public Medicaid healthcare provider, and traditionally we had cost settled all of our contracts. So as we moved into value-based purchasing, we allowed for profits from our provider network for the first time. We did put a 2% profit cap on all of our models, however, wanting to be good stewards of the public funding, and then also wanting to be able to reinvest any additional cost savings into more services. So in addition to that 2% profit, we also allow incentive payments for the outcomes that we want to see. And so the ACT model, being an evidence-based practice, is designed specifically to keep people out of inpatient hospitalization. And so if you look at this first slide, the solid green line in the middle is a 5% line where we have stated that's our stretch goal, that we would like providers to keep inpatient hospitalization for everyone they serve in ACT that has been in service for 90 days. So we give the first 90 days time to get interventions in place and things like that. then we will pay an incentive every time they keep hospitalizations at or below that number. So then you can see the faded lines in the background are quarter by quarter provider performance. And then the more solid lines are trend lines that you can see are trends over time. So this has 3 years of inpatient data, and it's showing us that we do have an upward trend over the course of time. And so this is the type of data that we use to determine where that stretch line is. Where is that incentive goal year over year as we progress? And so then you can even see in the chart at the bottom the quarters that the providers did or did not achieve that particular incentive payment. So each of these incentives is also paid separately with bonuses for the more incentives you achieve, then you can have like a bonus payment on top of that. And on the next slide, we're looking at our inpatient readmissions. So what's interesting about this slide, again, that green line at 3% is the stretch goal, is that we expect all readmissions, and we define that as someone going back into an acute care hospital within 30 days of their initial admission. And you know, we have 2 looks on this particular slide. So the larger graph again shows our overall percentage, and you can see the trend line for one provider is kind of going up, but one is staying steady and one is going down. And so what that does is it gives us the opportunity to work with provider B in this instance about, you know, why their trend for readmissions might be going up, but it still tells us that our goal or our incentive line is good, and we can maintain that overall expectation for our network. The smaller graph here just keeps an overall systemic perspective, so that takes our scale of 0 to 5% and puts it on a 100% scale, just to show network performance overall at keeping that consistently under 3%. And then the next slide is another incentive that we have, but this is one that where we wanted increased performance. So we want those trend lines that you see increasing. We have access here in Michigan to all medical and behavioral health adjudicated claims. And so we use that data in a population health management tool to give reports to our provider network. So they understand who they support, who has and who has not seen a primary care doctor in the past 12 months. We then incentivize them to assist people in making an appointment, arranging for transportation to get to the doctor, or to provide a basic health screen, which would consist of height, weight, BMI, blood pressure, and HbA1c if the person refuses to go to a primary care doctor. So we had been working on this for a couple years prior to this incentive, and what you can see is it really took us from the high 80s, low 90s, up into that higher, about 95% systemic average, with those 2 providers very close to 100% of full compliance. So as we moved toward integrated healthcare and really wanting to make sure that the people we serve had access to a full continuum of healthcare services, things like these incentives really helped us to kind of push things into the realm of what we wanted to see for those outcomes.
Okay, Nicole, this is great. I need to ask though, in this slide specifically. So of your providers, do you have a sense of how many of them can provide that primary care connection here, this coordination themselves, and how many are partnering with other organizations to get that?
So one thing that we did about 6 years ago now-ish, is we worked to start an FQHC here in our county, so a federally qualified healthcare center. And part of that startup of the FQHC, which is its own entity, it operates with its own budget now, it is not part of our business, but we co-located sites with a lot of our behavioral health care providers. And so that really provided a big bridge for our providers, and it provided good access for the people that we support, because even the people who might go to a provider location who is not co-located still can get easier access to that FQHC. They're always accepting new people. They gladly take people with Medicaid, in addition to serving people who are un- and underinsured. And in addition to the primary care, they also do women's specialty, OBGYN services, and dental care. So that was a huge game changer for us locally and in this county, was to get access to that. So that being said, most of the providers work very closely hand in hand with that local FQHC, but all of them that perform an ACT service also do have nurses on staff who are able and capable of doing that basic screen that I talked about that has the blood pressure, the HbA1c, height, weight, and BMI.
Excellent. So Chloe, do you want to jump ahead a little bit? Because I do, yeah, okay. we'll I think that may have jumped one slide too far, but you know, you will have noticed from the list on previous slides, and it's okay to stay right here, Chloe, but that nurses are on that list. So that's, as Nicole mentioned, that is a part of this whole care coordination. So you may be costing folks time who are an important part of your program, who may or may not actually be working for your organization, and that's where things can get a little tricky. If you're trying to demonstrate that you are having an active role in the outcomes that your payer is asking to have, but you don't control all the levers, that's where things can get a little bit complicated. So that's you know, for further conversation about, you know, more bi-directional integration possibly, and also maybe just sitting down with those various providers to see how do you share in the shared savings if in fact, you know, there are more than one organization that are creating inputs that get you to where you want to go. So that kind of complicates things a little bit. So we get to this in the next couple of slides, which are about that negotiation with your payers. And so this is kind of interesting. Early on, you've got issues, you know, that with patient attribution, right? So, you know, who do you get assigned to you? And this is a big deal. You might think to yourself, well, yeah, I've got, compared to the provider down the street, I've got a lot more difficult cases. Well, that's may in fact be the case. However, they may also be costing the system more money, and therefore you may have actually more leverage in your negotiations than someone who's seeing what, in unfortunate terms, you call the worried well to some extent, who have, you know, lower level issues and don't cost the system overall quite as much money. They don't result in as many incarcerations, and they don't have as many interactions with inpatient hospital psychiatric wards, but at the same time, the system doesn't spend as much time and energy looking at those people. So, you know, think about your seriously mentally ill patients to some extent in these negotiations, as, you know, these are the high cost folks that you can work to try to help improve their outcomes and reduce those costs. And some of the ways you can do that is through the performance improvement projects, right? If you're working with an MCO, they have to put together some payment improvement projects. So performance improvement projects, excuse me. Be that kid in the classroom who's waving their hand, hey, call on me, call on me. Don't wait for them to kind of say, gee, we've come up with this PIP program and we want you to participate. You know, if you've got something out there that is kind of novel, something you've worked on, something a little bit different, propose it to your payer, right, as a performance improvement project, because they're going to be looking for it. And if you're already good at it or have developed it, then that's going to help you in the negotiations going down the road. You also got, you know, you can leverage your Medicaid managed care health plans when your ACO negotiations and innovations. All of that works along the same lines. And then farther down the road, you've got social risk adjustment, which is, you know, ties a little bit into what we talked about last week, which was, you know, social determinants of health. How do you categorize the risks that, you know, a patient represents to the system in the sense of costing because of situations in their life that they, you know, you don't necessarily control within the therapeutic environment. So you might, you know, you want to push the system, and I'm going to ask, I'll let you guys think about this for a minute, but I'm going to ask Anya and Nicole to talk about this a little bit, how they view this social risk adjustment idea, whether it's actually becoming reality yet, whether it's reflected kind of in the system just the way it is, or what kind of control could a payer and a provider, what kind of discussion do you have about, you know, differentiating people based on, the particular social risk. Are they homeless? Are they, without a job? Are they, whatever, the different aspects that could influence the severity and how of their particular issues and how that could work out. So do you guys have any response to that idea of social risk adjustment?
So I think how that plays out right now is really in terms of like our levels of care. And so those types of things that you had just mentioned are all part of the various functional assessments that we perform up front to kind of determine which level of care or which bundle of services would best help a person based on their level of need. So, someone in our ACT program that we talked about today could have all of the things that you just described in addition to, experiencing severe and active psychosis and a history of multiple hospitalizations, which would put them in ACT, and then we pay for that accordingly. But the other thing would be if they needed the ancillary services. So when Anya talked about ancillary services, like community living support. So if someone, lives on their own or they have a roommate and they need some basic assistance with, shopping or training around independence with ADLs, that kind of thing, we pay for that in a separate bundle based on the average cost per unit for that particular service. So if there were particular services that required specialty staff or specialty requirements or things like that that someone brought to us and they could demonstrate outcomes or they wanted to do a pilot with an outcome, I mean, we are always open to that discussion. I'm pretty sure I can speak for both Anya and myself when I would say if someone would come to us with those ideas, that's kind of what we live for. So we would love to hear that and partner with a provider around, potential changes that way. From a costing perspective, I'm not sure if Anya had anything else that she would want to add to that.
No, not necessarily.
Okay. So, Chloe, you want to move slides? We have 3 slides here, and about 8 minutes left. I guess first I'll ask Chloe if we have any questions yet from the audience. It looks like we don't at this point.
We don't have any questions yet, but again, feel free to ask questions on the right-hand side of the GoToWebinar toolbar.
Great, thanks. So we have 3 slides here that talk about this negotiating process, if you will, with your payers, and there's 3 levels at which you need to interact with them. 3 things you need to bring up. The first one here being the measurement and metrics. Up front, it's important to collaborate with your payers as to what you're going to be measured on. Right? Does everyone understand it? Does everyone have an input as to what those might be? And at what levels are they going to be at, right? You need upfront to have that input so that you can actually make them accomplishable. They might be things that you measure, but they're set at a scale that you can't actually achieve or haven't in the past. And so your potential for achieving some kind of value-based reward, if you will, in the end, goes down, which can, it can impact the incentive of the providers to get, really behind this idea. So these are things that have to happen up front. We need to, measure that, figure out what the measures are, and then make sure that we're open, both sides are open to modifying them over time as you demonstrate, ability to meet them. Next slide, please, Chloe. So that, again, logically, is that transparency issue. So your data needs to be not only accurate and complete, but you have to be able to share it. You have to be willing to share it, and it's great if on some level, electronically you can share it. Maybe perhaps through the use of a whatever electronic health system you might be using, and so everyone can kind of look in and see what's going on. There's trust that gets built up, and along with that, you're promoting this development of the program going forward and that relationship that you have with the payer. And this is all going to work in the provider and the payer's benefit, right? We're going to start hitting the quadruple aims much more closely if we're at that situation where we're all talking the same language and we're working towards the same goal. Next slide. Okay, and then this is the last bit. So we're all after trying to find those populations and those areas that cost the system the most, and where the individual needs of those people who fall into those groups may be the highest. So it could take a long time to get this work done. So don't assume that you're going to, don't set yourself aspirational goals in year one. And when you don't achieve them, you don't get any payment or reward, and everyone's disappointed. Realize that it may take several years for you to get the outcomes that you're looking for, but that you have faith in the two parties, the payer and the provider, are working towards that, setting up the systems that'll get you to where you're going to go. But it may not be an instant, gratification, if you will. You may not automatically start reaping the rewards of the value-based payment aspect of this, the shared savings. It may take a while, but that's still a worthwhile effort to make. Next slide, please. All right, Bob, I'm going to hand this one over to you. Hopefully it's not a huge shocker to you. We've gone through this before, but maybe you could talk a little bit about your experience with negotiating with payers as well, and also the fact that this applies to your whole team and not just the providers.
Yeah, I think the message here is you are negotiating with your payers, and you are trying to put the best foot forward in that respect. But internally, you have to make sure that your internal partners understand the numbers and understand how you're using them. I think it's critical to use it as a management tool so that everyone knows what your costs are, everyone knows where your revenue's coming from, everyone can see what the outcome of all your effort is. And to the last point down here, provider teams will not miss it if overhead is a large flat number. That's very true. The challenge is that providers, and I'm providing providers in our environment, are looking at the circumstance where you're asking me how many clients I'm seeing and how many hours I'm spending in the clinic, but how do I know what you're doing? How do I know that you're not overstaffed in patient accounts? How do I know that you don't have too many people in finance? And that's where the drain on our profitability comes, and I have to work harder. I think that opening the books internally is every bit as important as externally. So I think that's the message here, that you have to be able to sit down with each part of your organization, open the books up, make them understand exactly where everything is coming from, and have a good understanding of it, so that when you're out doing your external negotiations, that all makes sense to them as well. That's what I
thought. Thanks. So the last couple of slides we're going to finish with here, with just a few minutes left. There are some recommendations in negotiating with your payers. There's the measures we talked about already, right? And is making sure you're clear and using your data to determine what levels at which you're going to be measured and what levels are going to earn you some kind of reward, hopefully. Then integration of services, right? So you can, it was interesting to hear from Nicole and Anya about what they're doing in Michigan as far as integration, actually setting up their own FQHC. I'm not sure I've heard that happening too often, but certainly you can cooperate with a local FQHC or some similar organization in integrating that care and generating those benefits. And then making sure that your efforts on the behavioral health side are adequately recognized and rewarded. And then, follow the money. That's an important part of this. That may mean, since the big money and many of the measures, if you will, especially in the CCBHC world now, which you may be aspiring to, have to do with, keeping people out of inpatient care. And so that's where the big money is. So you need to, and may want to, work with your hospital as well, in understanding what those costs are. So by avoiding those costs, you get some of that benefit, right? So it's kind of the weird thing. It's a lot of behavioral health is in just creating stability for your clients. Stability is a good goal, but it's difficult to put a dollar price tag on it. The dollar price tag comes with the instability, and perhaps the admission, which they went through on that ACT program, admission or readmission to an inpatient program is where the big dollars start to pile up. So that's where you want to chat with your hospital inpatient programs and see what you can do to kind of coordinate your activities and then build a system around that in which you get recognized for that. And then lastly, it's innovation. We talked about a little bit about that with the PIP program and the like. If you're doing things, be open to that. Have those discussions early on. If there are things you can see that could be doing better systematically that you've done, introduce it to your payer. Why not, right? And see if there isn't a way to create a program that might reward you. Okay, the last slide, Chloe. So this is just a real quick review of value-based payments to the extent they exist in the CCBHCs. That went from an 8-state demonstration program has now been increased to 10 states. I think it's fair to say we're going to be seeing this program go nationwide here before too long. And this is something you can certainly aspire to. If you don't have a true value-based program started up in your state yet, where there's upside risk and downside risk, you're not at that level 4, maybe even level 3. You still may be able to aspire to the PPS rate to increase what you get for your visits, and that can cover your costs. And along those lines, there are quality-based metrics that they get judged on, and you can see a few of them here. They're access related and they're maybe process related, and still they're not necessarily patient outcomes, but they are outcomes to the system that the system values. So you can start tracking that. Make sure your internal systems are capable of tracking that, and that you're connected to these other outside parties that may have an influence on those outcomes. Okay, we are at 6:01, and Chloe, I'm going to ask you to go to the last slide. Thank you. And here's our contact information, including Anya's and Nicole's. And let me once again thank Anya and Nicole for joining us today. This has been great to get your perspective. If you have questions, directly for any of us, feel free to contact us directly along those lines, and we'll be sure to get right back to you. So thanks for joining us today. Any from our speakers? Any final comments?
Nope, I appreciate Anya and Nicole joining us. It was very, very nice to have that input on the payer side. I think what it I think shows is that there is a collaboration that has to happen, and that we have to work together on both sides of this to do what's best for the people we serve.
Thanks, everyone. And I just want to open up the question box for just a couple more seconds, just in case if anyone does have a question. I know that we did run over on the time, but just want to make sure that everyone has the opportunity if they have a question before we close out this webinar. So I'm just going to leave it open for a few more seconds. Feel free to ask your question. But if we do not have anything that pops up, you can always ask through email on the contact list that we have on the slide.
So Dave, we're 8 for 8, just so you know.
and not allowing enough time for questions. I agree. Something to be said for consistency.
All right, so we don't have anything, but again, if you do have anything that you can think of, feel free to ask and send an email to any of these contacts on this last page here. And as soon as we close out this webinar, you will be directed to a very brief survey, and we appreciate any feedback that you're able to provide. Thank you so much, everybody, and have a great rest of your day.
Everybody.